Hey man, how you doing?
Good. How are you?
I'm well. So, thanks for joining us today. So, tell me how things are going, and tell me where you are so far. Um, how far are you in the 21-day game plan?
Things are going really good. I just finished the last cohort video last night, and I
Nice.
did the
Okay, cohort three.
yes,
Okay.
and then I did the 100 question quiz on like one of the private tutor ones that I watched, and I got the
Okay.
95 out of 100. And
Nice.
then
Okay.
I'm going to start doing the comprehensive ones that you emailed us or the diagnostic exams today.
Okay. So you've now done cohorts one, two, and three, and you've done all 8 sessions out of each.
Yes,
Nice. Okay. And so when is your test? All right. So let me just jot down some notes. When is your test date?
next Wednesday, the 29th at 11 a.m.
Okay. All right. So you're right exactly where you need to be. Um, so 29th. Okay, good. So that gives you a full week. So you're a week out from your test. At this point, you definitely want to jump in. Let's see. I think you don't have to do all the exams. Because there are some individual topic exams in class marker. You don't have to necessarily do those unless you're weak in a certain area. But
Okay.
those were created because those tend to be the weak topics for most people, like EKGs, Vaughan Williams classifications, endocrine emergencies, shock, things like that. So there are specific exams on those. If you or acid base is another big one. If you feel that you're weak in those individual topics, by all means, you can do those diagnostic exams, but or those topic exams. But at a minimum, I want you to do the diagnostic exams and then the final exams. So, do you know how to act? You've accessed it before,
Yes.
right?
Yeah.
Okay. So, if you'll go to, in fact, you can just go to, if you ever forget, you can go to under the 14 days program, go to class marker exams right here at the top.
Hmm.
And then there's a link here at the bottom.
Okay.
Okay. So, you can always get back to it. But when you go there, in fact, let me log in for just a moment. And give me just a moment. Let me get it pulled up for myself. Okay. So when you go there, you're going to, the only ones you will see are the ones that are assigned to you. So you'll only see the paramedic ones.
Okay.
And you definitely want to do these diagnostic exams. So there's diagnostic exams 1 through 5, and then there's a final exam 1B, final exam 2. So that's a
Okay.
total of 7 exams. If you were to do one a day starting today, you'll get through all of them.
Okay.
Okay. The other thing that you want to do now at this point, especially since you're in your final week, is you want to go let's see. Okay, right here under the 14 days program to the final week part. This is when you start like the rapid drill. So if we go 7 days before, it mentions starting the rapid drills today. Also on your new tracker, it'll mention that. Of
Okay.
course, to access those, you're going to go to the bonus resources. And have you used these before? The rapid drills
Yeah,
or the rapid drills audio?
I actually used the app, the Rapido audio today when I was mowing my lawn. I was actually listening to you while I was doing it for like an hour, so
Okay.
it worked out
So what
great.
I recommend you do is there's 700 of those. If you do about 100 a day starting today, um, you'll get through all of the rapid drills. Now, what you can do is you could just listen to it in your ear through the audio, or if you want to read it at the same time, then if you have time to sit down, then you can use the written set.
Okay.
But definitely use the audio every chance you can get and listen to it every day.
Okay.
Okay, it'll just kind of help keep the information fresh on your mind. And then for you, if you want to, let's say when you're about 5 days before, if you want to book a private session with me, we can. And what we would do in that session is we would go through questions together, and then I would do. So I have actually, it's in fact, it's the same document that it's under classroom 14 days. If you go right here to 5 days before,
Hmm.
There's this last 5 days review. And this is essentially what I would be going through with you, except I would be asking you these questions.
Okay.
Um, like I would literally walk through this sheet with you and figure out, for sure, do you know these topics, yes or no?
Okay.
Sometimes, like the way a question is written, somebody can answer a question just on a test, but they may not fundamentally know it well. It's just they're able to pick out enough clues, which is great for a test, but you still need to know this kind of thing in real life. And so if you decide to take us up on that, then that's what I would be doing with you. We would
Okay.
do questions together, and then I would actually go down that sheet from that 5 days. Like I'll pull up that exact sheet and we'll walk through every one of those things topic by topic and say, do you know it? Do you not know it? And if you don't know it, that's a fine time to find out before
Yeah.
you get into the real exam. Okay. Do you have any other questions?
Not at the moment, no.
Okay. So just kind of recap for me what your game plan is for the next 7 days.
Definitely going to go through the diagnostics exam. Going to try to do them once a day. But I was looking at your game plan. They said the day before, said maybe do 2 hours max studying and then nothing really after that. So
Correct.
if I can do, I might do like one or two tests a day to try to get it so I can get them done in 6 days versus seven since I'm
Sure.
off today. And then,
And it's like what's essential, even if you have to skip, like if you have to skip diagnostic exam one and then just start on two, that's
okay.
okay. But what you definitely want to do is, okay, so let's say, all right, your exam is on the 29th, right?
Hmm.
Okay. So, and today is the 22nd, 27th, 28th. Okay, cool. So, like on the 28th, this is where you would do, if you have time, you could do final exam number two there, then final exam one. All right. Diagnostic five, four, three, two. If, well, actually, you would have enough time to do all of them today.
Oh,
If
cool.
you started today, you would actually get them all done.
Awesome.
And then you definitely want to do rapid drills, like if you can start that today. So 1 through 100, 101 through 200, 201 through 300. And you can do this however you want to. This is just a pattern that you could use uh, so that you're not overwhelmed.
Hmm.
If you do it all in one sitting, it takes about 3 hours, unless you speed it up to double time, and then it's an hour and a half. But um, yeah, just work with your schedule and try to get it all in. But definitely, I want to make sure that you've gotten now. Even if what's probably better is if you had final exam done 2 days before, because that gives us enough time to review it and also figure out any weaknesses.
Okay.
Okay, so
That
just kind
works.
of work with your schedule and come up with something similar to this.
Yeah, sounds good.
Okay,
And then I
anything
also
else?
made a bunch of flashcards with like little tips and tricks that you got from your videos.
Okay.
Things that I remember from the previous test that I was like, man, I remember what that word was. So I put it down on an index card. And I'm just randomly quizzing myself on those words.
Nice. Okay.
So it's working.
And so how are you feeling overall? Like where are you today compared to however many weeks ago when you started?
I have so much more confidence in myself, honestly, and that's like the biggest part of what I didn't have before. Putting it, I can talk to you right now about questions, and we're good. I get into that room, and for some reason, it goes away. Like I get
No,
horrible
that's
test
okay. You
anxiety.
you're just going to do the same thing in the real test. Everything comes down to the 5-star medic method. Okay, I promise you. Um, number one, is there a safety concern? Because if there's a safety concern, that kind of trumps patient care, no matter how bad the patient is. So that's priority number one. Step number two of the 5-star medic method is: are they sick or not sick? The reason we figured that out is because here, let's just draw it out. So you tell me. So point number one is what? What did I just say?
Safety.
All right, safety. Okay. So this is all your stuff from bucket number one of the five buckets. So this is your BSI, scene safety, mechanism of injury, nature of illness, number of patients, need for additional resources. All of that is bucket number one. All of that is priority number one. Okay. Then number two is, are they sick or not sick? And the reason we try to figure that out is because if they're not sick, like if they describe a perfectly normal person, that means that you're not actually going to do anything. What you're going to do instead is just monitor them, give them a ride to the hospital, phone a friend, that kind of thing. But you're not actually going to do real interventions. However, if they are sick, then we do need to do something. And that doing something comes down to, are they are they
Stable or
stable or
unstable?
not? So we got to figure out unstable versus stable. Okay. And then all of our fixes. So if they're sick, we've got to fix them. If they're unstable, we've got to fix them now and rapid transport. All of our fixes. So we either fix or support. Of course, all of our fixes come down to oxygenation, ventilation, perfusion. Wait, what's happening here? Hold on. Okay. All of our fixes come down to oxygenation, ventilation, or perfusion. And it really is like this pattern will just come up over and over and over if you're following it. If you're following it, it makes the question so much easier. Okay. Because now there are times when you don't use this, and that's when they don't give you anything about a patient. Like if they're
Yeah.
just asking you some random question like, what's the mechanism of action for nitro? None of this applies because this only applies to patients.
Right.
Okay. But anytime they give you a patient, like, I want you to think through this and then constantly just say, what's the safest thing that I could do right now that keeps this patient from dying? It's not that we got to be the hero, it's that we've just got to make safe decisions over and over and over again. Okay.
Mm-hmm.
Now, so what happens if you have what happens if you have two answers or some of them? Okay. So if they give you, let's say they give you A, B, C, D, E, and they say pick two. Well, when it comes to picking two, we're still going to eliminate three. And things that we're going to eliminate are our seed tricks, anything that's outside of our scope, anything that's too expensive, anything that's too advanced too quickly, or anything that delays care. We eliminate all of those. Okay. So even if you have to pick, let's say they want you to pick two out of the five or pick three out of the six, you're still eliminating the wrong answers. Does that make
Mm-hmm.
sense? So
Yes.
it's even in those situations, it's not so much that you know the right answer, it's that you know how to eliminate the wrong answer. And then that leaves you with the right answer.
Mm-hmm.
Okay. And so let's say I have a situation where they give me five things and they want me to pick two. Well, it still comes down to this same thing. Okay. Is there a safety concern? Is this patient sick or not? Are they stable or not? Like this part about stable or not is very important. Let's say they give you, let's say they give you something and you've got a heart rate. The heart rate is either up or down, right? But let's say the heart rate is up and they're tachycardic. Well, if they're sick, they have symptoms. So now we have symptomatic tachycardia.
Mm-hmm.
Well, symptomatic tachycardia is treated differently if it's stable versus unstable. So, how would I treat symptomatic tachycardia that's stable?
Like vagal maneuvers.
Yeah, I'm going to start with a vagal maneuver. Well, I'm going to start with anything that's safe, making sure everything's safe. Then
Mm-hmm.
I go with a vagal maneuver. If that doesn't work, I'm going to do adenosine, then second adenosine, then I'll go to synchronized cardioversion. But what do I do if somebody is sick or symptomatic? They have symptomatic tachycardia and they're unstable.
Synchronized cardioversion.
Now I'm going to go straight to cardioversion. All right, let's use the same thing again. Watch this. What if I have somebody who's symptomatic and bradycardic and they're stable?
Give them atropine.
Okay, I'm going to start with atropine. My first dose is going to be what? Well, my first dose will be what?
1 milligram.
1 milligram. If I need to repeat it, how often can I repeat it?
five minutes,
Every 3 to 5 minutes.
35.
Okay, so I can repeat it twice so they can get up to 3 doses with a max of 3 milligrams. Okay, what if I have somebody who's symptomatic uh, bradycardic unstable? So symptomatic unstable bradycardia, what would I do there?
Pacing,
Okay, so you
transcutaneous
see
pacing.
what I mean? This 5-star medic method comes up in like over and over and over again once you know how to use it.
Right.
Okay, now no matter what the situation is, all my fixes come to, like they could tell me, like, okay, let's use this as an example. Let's say ultimately we get a question down to it's a ventilation problem. Now let me show you how this works practically. Let's say we have a ventilation problem, right? Some examples of that. So all of this points to respiratory failure. Now, what could be the cause though? Like what could be the details in the question that change the scenario? It could be an opiate overdose. It could be a benzo overdose. It could be some kind of major trauma. It could be a head injury. But it could be alcohol intoxication.
Mhm.
But no matter, so all of these things are details, but they all are the same problem.
Right.
Okay. Now, obviously, for instance, okay, in an opiate overdose, the additional thing that I have to do, okay, well, let's do it this way. Let's say all of these are ventilation problems. So, what's my fix for a ventilation problem?
BVM or with an airway adjunct and oxygen.
There you go. BVM, and that's either going to be an OPA, an NPA plus O2. Okay. So, let's say they give me a question where they say pick two out of the three, right?
Hmm.
Well, what's the first problem? Well, the first problem or the first correction is I got to do something with the BVM. If they have oxygen as a separate answer, well, that's probably answer number two. If they
Hmm.
have adjunct as another answer, that's probably the next answer. Now, what if they in the answer choices, what if they only say BVM and they leave off these two? Well, I got to go with that because that's what the test writer gave me. But what if they give me a scenario about opiate overdose and they want me to pick two of the things? Well, BVM is first because it addresses the actual problem. And then for opiate overdose, the second thing is going to be Narcan
Narcan.
or naloxone. Okay. What if they give me a benzo overdose? Well, I got to fix the main problem first. So if I had to put these in order, so if I got to put them in order, of number one, number two, number three, number four, number one always has to be what fixes the actual problem. So for all of these ventilation issues, what fixes the actual problem has to be a BVM. And then what comes in the second spot or third spot deals with the extra details. So for a benzo overdose, what's going to be in the second spot?
Uh, Fluzim. I don't know how to
Okay,
pronounce it. Fluzim.
flumazenil or
That's it.
ramazacon. Yeah,
Yeah.
okay. Let's say they gave me a head injury. BVM is probably the first spot. What would be the second option there?
Uh,
What if they wanted a drug? What would be the drug that would be like the second thing to do to
with
decrease the
lidocaine.
intracranial pressure?
Lidocaine. Then
Why would you do the lidocaine?
I'm not remembering why. I remember in school they taught us something about lidocaine that it could reduce intracranial pressure, but that might have
Okay,
been during
and
like an
that's
indication.
primarily something that we would do in kids, but it's not so much that the lidocaine is reducing the pressure. What you really want is something that's going to cause more of a fluid shift, and that's going to be some kind of diuretic, and that's going to be an osmotic diuretic like mannitol.
Okay,
Okay,
mannitol.
so mannitol would be kind of the drug of choice for um, a head injury. Why do you use something like mannitol in a head injury versus saline or ringers?
Because I mean, you don't want to put too much more. You don't want to put too much fluid on it, and I mean, ringers, regular saline. I remember you saying it could cause shock because it has chloride in it,
Okay, nice. Okay,
and the
good.
ringers also has a little bit of um, potassium in it that can I forgot how you said lactated ringers could hurt it too for cranial pressure.
Okay, so this is what it comes down to. It comes down to the nature of the fluids. Remember, we have isotonic. That okay. When you give an isotonic, the cell stays the same size. Then you have a hypotonic, and then you have a hypertonic. Okay. Now, so the one on the left, this is the original cell. No, I'm sorry, I did that wrong. Let's do it the other way. The one on the right is the fluid that you're going to give. And then the one on the left is how the cell changes sizes. So if you give a hypotonic solution, the cell gets bigger. If you give a hypertonic solution, the cell shrinks. Okay. The reason that you're giving, like an example of a hypotonic solution would be what?
Um,
That's going to be like pure
like,
water
okay.
or half normal saline. Okay. If you give something like that, it causes the cell to swell. So, and this is also how another way to tie something like this in. If they give you a scenario about, okay, somebody knocked out their tooth, and what do you do to preserve the tooth? And they say, okay, put it in milk. The reason you don't put it in sterile water is because even though you carry sterile water, and that seems like, oh, well, what would be wrong with that? It doesn't have any bacteria, it's just water. But because it's just water with no electrolytes, what it does is it causes the cells to swell, and then the cells swell to the point of the membrane getting damaged, and then the cell dies. So if
Mm-hmm.
you put a tooth in just sterile water, the cells of the tooth actually end up dying, and then you destroy the dental root. Okay. The reason we don't want to give, or the reason we do want to give something like mannitol is it's a hypertonic solution, because think about it. If they have increased intracranial pressure, there's a lot of pressure, a lot of volume there, that's things are swelling. We
Mm-hmm.
need those cells to shrink because now that helps with the swelling. Does that make sense?
Yes. Yeah, it
So
does.
that's why we're using a hypertonic solution like mannitol in a head injury, is it causes the cells to shrink because they're already swollen. We don't want to make them swell anymore. If I give them a hypotonic solution, their cells swell even more.
Okay.
Okay. Does that make sense?
Yeah.
Um, but so what I was saying is all of these things are just details. But we still got to get it down to like, what's the actual problem? Okay. Let's use the other example. Let's say we have an oxygenation problem. Well, our two fixes for oxygenation problems are doing something with the airway or giving them oxygen. Okay.
Mm-hmm.
So, what would be an airway problem? Well, that could be a burn with superheated gases in the airway. That could be anaphylaxis. That could be they ingested some kind of caustic substance. They have something like epiglottitis or croup, which are airway situations. So, all of these are still details. So notice how I just started a list. Burns, anaphylaxis, right? So
Mm-hmm.
all of those they still fundamentally come down to it's an oxygenation problem where we got to do something with the airway. But let's say the detail is called anaphylaxis. Okay. What's the thing that's going to kill them first? It's the airway closing. So, what would be my first line treatment for anaphylaxis to prevent the airway from closing?
Epi.
That's going to be my epi. But then if they're having an oxygenation problem, what's going to be like the next thing? Well, I probably am going to have to give them oxygen. What else am I going to have to do? Well, I'm probably going to have to give albuterol. What else am I going to need to do? Well, because of the histamine release, I'm probably going to need to give an antihistamine. That's going to be Benadryl or diphenhydramine. Okay, because of the inflammation that it's causing, I'm probably going to need to give solumedrol, so methylprednisolone, right? So it doesn't matter how they ask a question. We still got it down to what is the primary problem. And then we just add on other things to treat the other problems. Does that make sense?
Yeah, very
And we do
much.
this over and over and over, question after question, just one question at a time. Now, what if they give you a situation where you have your en route, your scene, and your post scene questions? Okay. Sometimes people get tripped up by these, but at the end of the day, it's still a question. Okay. It doesn't like it's just worded differently or it's just set up differently. But at the end of the day, it's still a question. What is, how is, what is the next best step, or
Hmm.
something like that? It's still a question. So even though they present it this way as en route, scene, and post scene, you still just get it down to what is the actual question being asked. Now, sometimes I need some details in the story, or I need to know, like, what have they done already?
Hmm.
Sometimes I don't need to know it at all. Like, there are certain questions where, let's say they give you a scene question and they say it's a scene question, but the actual question is put these drugs, match these drugs. Okay, so you got a list of drugs over here, and then you got a list of conditions over here. And all they want you to do is match the drug with the condition. They presented it as a scene question, but the actual question was match the drugs.
Right.
None of this stuff in the story made any difference at all. Does that make sense?
Hmm. Yeah. Yeah, I've
So,
gotten those before.
yeah, and don't get tripped up on those. Still, it's still just a question, just asked in a different way. Okay.
I gotcha. Yeah.
What other questions do you have?
Um, Honestly, really nothing. Really, I did struggle a lot with the on scene and transporting questions. I feel like I may have jumped the gun and like did the whole like this is a paramedic exam. They probably want paramedic answers only, and I probably skipped over the most basic answer or scene safety answers and everything.
Okay.
But so I feel like if I slow down, even like yesterday when I did that 100 question quiz, if there was a couple questions, I'm like, man, it could be A or B, or it could be B or C. And I'm like, you know what? And I went back and I was like, it's not A because of this. It's not D because of this. And I was able to eliminate it. I'm like, oh, so it's B. That makes sense now.
Okay.
So it worked
And
out.
elimination is probably one of your best techniques. Like you just eliminate down to the right answer. Even if you
Yeah.
don't know the right answer, eliminate everything else that's wrong. So as you're going through answer choices, constantly ask, what would make this thing wrong?
Mm,
Like, how could I, what about this? What about these words? There's something in here that makes this answer wrong. And when you
right.
can figure out what's wrong, sometimes the only thing that's left is what's right.
Right. And
Okay.
reading the question and the answers slow, I can't even tell you how much that's helped me because even some of the answers it'll say like delay this to do this. I'm like, well, that's obviously not the answer. And it's just
Sure.
like, I used to read them so fast I would skip delay and just
Okay.
it was, learned a lot.
uh, any other questions? And if you'll watch this session under 2 days before, I think
Mhm.
you said you did that one, or
I
you
did
you
watch
did
it.
the
Yeah.
questions under it. But if you'll watch that video where I was actually going through with Maris,
Yeah, I did
we
watch it. It
actually
was
go
great.
through lots of questions. Say that again.
I did watch it too. I watched it and then took the questions right afterwards. So it was good.
Okay. But if you can just, you may want to rewatch that one video because it actually has multiple question types in that session. And
Okay.
that's going to be very similar to what the real exam is going to be like.
Okay.
Okay.
Yeah.
All right. Who else do we have there? How you doing, my man?
I'm good. I'm just hanging out,
Okay. Hey,
just
so
listening
as
in.
somebody who so Billy, this is great. So we've got Lucian here. So Lucian was actually one of the people who came through cohort 1. He's just popping in today. So Lucian, what advice would you tell? So Billy's on his 6th attempt and he's his confidence has definitely changed. Like I saw him when we did the ACLS PALS review last week. He was answering questions like left and right. What advice would you give him as somebody who came through the program, passed on your next attempt with us? What advice would you give Billy?
Well, I can tell you
And
you're doing
nice
everything
haircut, by the
right
way.
so far. Oh, I did it myself. Thank you. No, but I can tell you you're doing everything right so far. as far as being present. I think that's huge. I've seen like 4 different people cycle through this and leave and whatnot. As soon as I joined and I saw there was only one person in here, I was like, oh, that's huge for whoever this guy is, because I remember being in cohort 1 and going through 1, 2, and 3 and whatnot, and seeing like it's only me and one other person, and you get more of a direct interaction with Joshua than, oh, you buy the program and then you're just watching replays. So I
Yeah.
can say that's huge. So be present for all of those. I'm sorry, my daughter got nuts in the cover of a dog. But be present in those for sure. And then just go through his steps, like the 5-star medic method, OVP, all of that stuff, man. I can't tell you how much that helped me. Going through the test that way, whenever I showed up for my final attempt, I just memory dumped all that stuff. And that was the biggest game changer for me. Be present for sure. Use what he tells you, and it'll make a huge difference.
Sweet.
And then another thing, I was coming in here because I was on shift yesterday. Like I got off this morning, and it's my second shift actually working as a paramedic.
Oh
And so I'm
wow.
going through orientation right now. Like I've got preceptors with me. But yesterday I had a real good call and made me think about Joshua. And the only reason that this call stuck with me is because like through medic school, through like the national, through Joshua, all of that, I have gotten the same exact kind of call, like in my head, going through it step by step. And you want to guess what it was, Joshua?
What's that?
It was an anaphylactic reaction. However, this time it wasn't an adult, it was a 5-year-old kid.
Okay.
And we got dispatched for a breathing problems call. Said 6-year-old friend said he was wheezing, and that's all we got in the notes. It said nothing else. So
Mm.
I'm going through already thinking, me and my medic partner were like pulling up our 1 Dose app or hand tevi, figuring out
Okay.
dosages. Like, okay, if we need to give him epi, this is what we like. We already know this is the dose. If we need to give him
Nice.
that, this is gonna be the dose. Just going into it. And so I'm the first one in the house. There's like 15 kids here, and I can immediately find out which one was the one that needed help. This little boy walks up to me. He's like, I'm like saying, I'm real sick. Can you please help me? Urticaria all over the face, the neck,
Okay.
the arms. And immediately, as soon as I saw him, I looked back at my partner. He's walking back to the truck to grab some stuff. So I start
Nice.
going through my assessment. And once I get to lung sounds, they said that he was audibly wheezing before we
Mm-hmm.
got there.
Okay.
I'm listening to lung sounds. They're now diminished.
Okay.
And
That
so
means
we
he's getting
immediately
worse.
give, yeah, absolutely. Immediately get epi on board. We give IM epi, point 2, immediately give Benadryl, started doing eb treatment, and get him loaded up into the truck. And everything just happened so fast that it was like I didn't even have time to think. We already knew what dosages we needed. We already knew what we were going to give them. Already knew, okay, anaphylactic reaction, epi immediately. Then you're going to give Benadryl. Then you're going to give Adunab. Then you're going to give Solu-Medrol. All these things just started falling in place. And like by the time we got to the hospital, we responded to him, and this kid looked like a whole different person. All the highs were gone. He
Sure.
started listening to lung sounds. Everything was moving perfect, and he
How did
started
that
to
make
feel
you feel,
better.
Lucian?
That was the first call that I've had as a paramedic where I saw a difference happen.
Wow.
And that call just made me reminded me of going through, oh, you got your first reaction and you don't really have anything to it. And then your second one is whenever
Sure.
you're histamine, and like just going through all of that and thinking about it, I was like, this is crazy, because this kid had 0 known allergies before.
Okay.
And now he's got ant bites all over him, and now he's having this anaphylactic reaction. And
Okay.
so definitely was a call that will probably stick with me for a long time.
I was going to
But
say, you're
but
going to
did
remember
it
that for the
feel?
rest of your life.
Go ahead. Say that again, Billy.
He's going to remember that call for the rest of his life.
Yeah. And
Yeah.
and Lucian, did it feel good knowing that your knowledge was better?
Oh yeah, absolutely. And even I had like 6 paramedics on scene with me and an EMS supervisor. And they all said, I mean, I've got nothing to critique. You did everything how you should, especially with it being a pediatric, higher acuity, higher, your tensions are going to be up there. Being a
Mm-hmm.
new medic, they all said, you did great. Like, I don't have anything to say. Like, you did exactly what you were supposed to do. And it's because I've gone over that same exact thing so many times.
Wow, that's awesome. And one of the things that I'll say, especially being a new medic, is okay. So just prime example, just yesterday, a medic reached out to me. So um, you remember Sheminsky that came? You probably saw her some in cohort 1. So she sent me a 12 lead yesterday. She she had an inferior STEMI and an SVT patient yesterday, like
Oh,
back to back.
wow.
Or maybe I think she sent it to me yesterday. Maybe it happened the day before. Um, but the inferior STEMI with so elevation in 2-3 AVF, depression in the lateral leads,
Mm,
and she had a SVT. Patient's heart rate was like 188, something like that. and
hmm
but I was like, hey, you need to go back and watch the ACLS PALS review because we went over all of this. And what I would say, and the same for you, go to the ACLS PALS review. It has been uploaded under the replay. So under cohort, go to the 14 days program at the bottom under the replays. Go to
hmm
it'll be the last one because it was just last week. Go to that ACLS PALS review. It's 2.5 hours, 2 hours, 2 hours 45 minutes or something like that. But we cover a lot of topics because we cover symptomatic bradycardia, stable and unstable, symptomatic
hmm
tachycardia, stable and unstable, cardiac arrest. Um, but those are calls that you're not running on every shift. And so,
Right.
like I told you guys before, anything that you haven't done in the last week, you want to make sure that you're reviewing it constantly.
Yeah.
So glad to see you, my man.
Oh, yeah. I'm reviewing everything so far because of me being in orientation. They're expecting me. I mean, I've got a protocol, but larger than the Bible, and
Okay.
it's like ridiculous. And so I'm expected to know the protocol like inside and out, obviously. And so I'm getting
And
quizzed on
here's
the
what I would say.
protocol.
Here's
And
what will help you, because the reason a lot of people struggle with their protocols is you're just trying to memorize protocols, right?
hmm
What I want you to do is take your protocol and then frame everything through the context of oxygenation, ventilation, perfusion, and say, every one of these treatments, which one of the three things does it fix?
hmm
Because those are the options. The options are oxygenation, ventilation, perfusion. Every one of those protocols has to tie to one of those three.
right.
When you can now take your protocol and say, oh, I know why we're doing this because it fixes ventilation, or this fixes perfusion, or this
hmm
improves oxygenation. Now you're not having to memorize a list of protocols. You're just having to say, okay, what's the main problem? Is it oxygenation, ventilation, or perfusion? And what can I now do to improve oxygenation, ventilation, and or perfusion? And I
I
promise you,
will
if you'll do
say
this over and
that,
over and over, like
yeah,
you're gonna see this pattern jump out. It'll just scream at you.
I will say that going through our protocol, I never really felt like or have felt like I need to memorize the protocol.
Hmm.
It's more of, oh, we do this just a little bit different. Or,
Okay,
oh, I got to remember these drug dosages because those are the dosages that we use. We don't use a
sure.
lot of ranges. And then if we do use ranges, it's usually just a set number that we'll go to. Right. So it's
Okay,
like, okay, you'll give whatever at a 1 to 2 range, like ketamine's 1 to 2 mgs per kg for sedation. We'll just go straight to one first.
okay.
Um, so it's just memorizing that stuff. But even like yesterday, some of my preceptors were going over drug dosages, and we've got a brand new EMT with us, and he starts medic school in like January or something like that. And he was sitting in on it, and he was asking us questions, and I was answering the questions, and the preceptor was kind of looking at me because I was going through exactly how you were. I remember how the conversation came up. We were talking about cardizem. He was like,
Hmm.
"What's the classification of cardizem? Like, is that whatever?" And I was like, the preceptor kind of looked at me because he didn't know, and I was like, "How do you not know? Like, it's a calcium channel blocker. It's a non-dihydropyridine. What do you mean?"
I love it. I love it.
Yeah. So just remember,
Wait,
like
but hold on,
knowing
hold
that
on.
stuff.
You said that. So who asked the question?
It was an EMT that asked the question.
Okay, and then the preceptor is a paramedic.
Yes.
Okay, but the preceptor didn't know, right?
Yeah. No.
Okay. And that's what I tell you. You have so many people out there who are 950 medics who pass the test, but like when things matter, there's a disconnect.
Right.
But you were able to be like, hey, that's a non-dihydropyridine calcium
Right.
channel blocker, which is exactly what it is.
Yeah. And that was just
I
one
love
of the
it.
things that I know. And I was like, I know exactly what that classification is because we were going through like a lot of that stuff, talking about like the sodium potassium pump and different ways that a lot of the cardiac drugs affect the heart. And so just
Okay.
talking about like SVT and like what is actually going on between like the SA node and the AV node and how it's just like there's a supercharge going on, and then talking about
So
AFib,
check
how
this
there's a
out.
bunch of SA nodes going on.
So typically when you're given a cardiac drug, it's because there's a perfusion issue. Remember,
Right.
everything comes down to oxygenation, ventilation, perfusion. Most cardiac drugs that you give fall under the perfusion category. Well, there's one perfusion equation, and that what do you remember what it is?
Yeah, it's heart rate equals
Or BP
or
equals
blood pressure equals heart rate times stroke volume times systemic vascular resistance.
nice. All so I promise you, every medication that you give comes down to this.
Right.
Okay. Like if you're giving something, okay, so let's say you're giving a drug like cardizem, it's a calcium channel blocker. It's got to work on one of these things.
Mm-hmm.
So the main thing that the calcium channel blocker is doing is working right here. It is decreasing systemic vascular resistance by causing vasodilation. Okay. Because a calcium channel blocker, what it does is it primarily dilates the arteriole. That decreases the resistance. That in turn decreases the blood pressure and or decreases the heart rate. Mainly it's resistance and blood pressure. Okay. But every drug that we give, especially every cardiac drug, kind of comes down to this. Okay. Let's say I watch this. Let's say I give a cardiac, you say, well, I'm gonna give aspirin. Where does aspirin work in these things? It's got to work on one of them. Remember, because this is the only option. This is the equation.
Mm-hmm.
So where would aspirin work in this situation? Why am I giving aspirin? How does aspirin restore perfusion? It's got to work somewhere in here. Where
Well, I
would you
know
say?
there's 4 classifications of aspirin.
Yeah. Okay. but how
Uh,
does aspirin work? If you had to pick which one of these things is it primarily working on, what would you say?
I would think the resistance, right?
Oh, okay. Tie that in. So we said that aspirin works on resistance. How?
Because it binds with irreversibly binds with COX 1 and 2, and it's like an anti-plate aggregator. So
Okay, keep going.
um,
This man, I should have been recording. Well, you know what? I'll take the Zoom recording because this needs to go up. Keep going.
I'm trying to remember how to word it, but it's like it.
No, you're on the right track. Okay, so let me show you what it is. Let me help you out. What we're trying to do is prevent these platelets from clumping up because as these platelets clump up, then they form a clot. And if I have a clot, a clot is going to increase resistance. So if I prevent the clot from forming, I decrease the resistance. Does that make sense?
Yeah.
mhm.
Okay. So, and I'm telling you, every single drug. All right, let's take another drug. Let's take nitro. All right, so let's put in nitro. I'm giving it because there's a perfusion problem. How does nitro work?
It's a
Which one of these things is
vasodilator.
it working on?
So
Is it working
systemic
on blood
vascular
pressure, heart
resistance.
rates? Say it again.
Your systemic vascular resistance.
How? Okay, so
Because
you're
it's a
saying nitro.
vasodilator.
Say it again.
It's a vasodilator.
Okay, now nitro, what's its main class first? Before it's a vasodilator,
A venodilator.
it's a venodilator. So a venodilator works on it dilates veins. And when I dilate a vein, if I dilate a vein, now I keep blood down like in the feet. And what is that going to do? So if I keep all this blood down in the feet, that means less blood is coming to the heart. And so if less blood volume is coming to the heart, which one of these things does it affect?
Stroke volume.
Stroke volume. That's your decrease in preload.
Let me get you some water.
Okay. So nitro, the venodilation, is the stroke volume effect. That's your decrease in preload. Okay. Now your vasodilation effect of nitro, that dilates arterioles. Arterioles, if we dilate an arteriole, what does that do?
Drop in blood pressure.
That's going to decrease the resistance and then decrease the blood pressure. So you see how all I did is I took that same equation and we just applied multiple medications in one equation.
Right.
That's the equation for everything, for every cardiac med. Give me another one. So we just did a calcium channel blocker. Like which one did we use?
We used cardizem.
Cardizem. Okay. So diltiazem.
Well, you could try. Try never.
Cardizem. Okay. But I could do this for any of them. Okay. Let's say I put somebody on a beta blocker. So any of the laws, how's that going to work?
Longer.
So if I do a beta blocker, where in this equation does it work?
Drop the heart rate.
It's going to drop the heart rate. And when I drop the heart rate, I also drop the blood pressure. That's why beta blockers are used when they have tachycardia or high blood pressure. Okay. What if I do so if I do a calcium channel blocker, we just did that, like cardizem. Of course, we have two flavors of that, but primarily the calcium channel blocker is going to work on the resistance part. So it's going to decrease the resistance, which also decreases the blood pressure. Okay. What's another cardiac drug that we give? Okay, let's go with adenosine. All right, get me to this for adenosine.
Adenosine. Yeah.
Okay, primarily we're giving it because the heart rate is through the roof. And remember that heart rate times stroke volume is cardiac output. So as this heart rate goes dangerously high, the stroke volume goes dangerously low. Thus, we're going to have decreased cardiac output. So we're primarily giving it here. But when we bring down this heart rate, eventually we also may bring down the blood pressure. So even though people don't talk about adenosine can lower blood pressure, that's just kind of a result that happens. That's not why we're doing it, but that's one of the things that could happen. All right, all right, so let's say epi. We give somebody epi. Get me back to the same equation. Notice I have one equation. No matter all the different drugs, those are just details, but it still comes down to one concept. So let's say if I have epi, where in this equation is epi working?
Epi works on your heart rate and your systemic vascular resistance.
Okay, so epi definitely. All right, so hold on. What are the three properties of epis?
Alpha 1.
Beta 1, beta 2.
Alpha 1, beta 1, beta 2. Okay. The alpha 1 effect, where does it work?
Works on your heart
rate.
Alpha 1
constricts your blood vessels.
So alpha 1 causes vasoconstriction. So if I cause vasoconstriction, I squeeze the blood vessel, that's going to increase the resistance. And when I increase the resistance, that will in turn increase the heart rate and increase the blood pressure. All right, that's why we're giving it often, is because they're going into shock and their blood pressure is low. We need to increase this blood pressure. Okay, but because of the beta 1 effect, it's also going to increase their heart rate. So notice how I'm just using the same equation over and over and over. It's just one concept that I'm working from. All the medicines, those are just details. Does that make sense? And that's why I say everything really does come down to oxygenation, ventilation, perfusion. It's just most people were never taught it this way. And so, it's like revolutionary when I teach it like this. But what it does is it teaches you all these patterns that I wish most people taught. Does that make sense, Billy?
Yeah, no, it really does.
Can you see how much this comes up about oxygenation, ventilation, perfusion?
Yeah, especially thinking back to my past tests. Yeah, I could definitely see it.
Okay. And like I say, do this with everything. In fact, one of the things that you can do is go into the it's under there's a OVP thing I did. I forget where it is. Let's see. It's one of these. It's maybe it's this one. It is. So I went through and I figured out like all these different kinds of situations, and I broke it down into like, is it mainly an oxygenation, ventilation, or perfusion problem?
Mm-hmm.
This would be a great thing to review. Billy, this would be a great thing to review because it kind of helps you organize most of your problems. And these happen to be the things that are heavily tested.
Okay.
Okay. So how I got to it is under the 14 days program, under Read First Introduction, there's a it's the handout for OVP video.
Okay.
Okay.
Yeah.
All right. Anything else, my man? Is there anything you want to go over since you're on with me? Otherwise, I don't have anything else.
The only question for some reason, because I've had a lot of aha moments, like, light bulbs that come on throughout this whole thing. So
Okay.
the only thing I keep forgetting is like but there's like a formula or for like pediatric tubes, whether they're cuffed or uncuffed.
Yeah.
Because I've gotten a few questions on that direction. For some reason, I always forget what the formula is.
Okay. And so let me just show you something. Let's go to, we're going to go to classroom. We're going to go to bonus resources, comprehensive study guide. And Lucian, check out the updated comprehensive study guide. It's a lot. So I'm going to just do a search for ET tube. Let's see. Let's find where it is. Right here. And I have a thing of formulas right here for ET tubes. Okay. So we say ET tube times 4 is the approximate chest tube size. ET tube times 3 is how deep you insert it.
Mm-hmm.
And then ET tube times 2 is the approximate size of the suction or OG tube. Okay. Now okay, I know what you mean though. Let's see. Oh, I probably need to add that. I actually don't remember that part. Let's see. And it's less likely that did you have that specific question?
So like I remember one I was given, it was like a scenario where you had to intubate a pediatric, and it was given all 4 choices were tube sizes, but one was a cuffed size, or 2 were cuffed and 2 were uncuffed, and they wanted you to pick the right one for size wise.
Okay. And
age
then what
divided by 4 plus 3.5, right?
Okay, so it's age
For
divided
cuffed?
by, so for uncuffed, it's age divided by 4 plus 4. For cuffed, it's age divided by 4 plus 3.5. All right, and I'll actually add this to the study guide because I realized that wasn't there. So I'll add that.
Easy enough.
Okay. Now, what's the difference though, cuffed versus uncuffed?
That was going to be my next question to you, honestly.
Okay. So if I have all right. So obviously I'm putting this tube into the trachea, right? Okay. And of course we're going to, where does the tube need to end up ultimately? So I want the tube to be just above the carina. So I want the end of the tube to kind of end here. Okay. Now, the reason for the cuffed versus uncuffed is if I use an uncuffed tube, it's just like a straw. It's just like a tube. The thing with an uncuffed tube is it doesn't totally block off the airway. So some things could like come back up from the esophagus and end up going down into the airway.
Okay.
But if I have a cuff tube, there's a little balloon that goes around here and it kind of blocks off. So it prevents things from coming back up the esophagus and going down the airway because there's now a balloon in the way. So the cuff just kind of better protects the airway.
Okay.
All right. The issue though is you don't want to overinflate the cuff. You know how like on an adult ET tube, a lot of times people just put 10 cc's of air in.
Mm-hmm.
The problem with that is if I keep putting too much air in here, there's pressure that builds up inside this closed space, and this pressure presses on the tissue surrounding it. And now you can cause tissue ischemia or tissue necrosis from too much pressure. It's pressing on the tissue surrounding the cuff. Make sense?
Okay. Yeah.
So instead of just automatically putting 10 cc's of air in, you want to put just enough air to hold the tube in place to keep it from moving up and down. And the better way is, you know how like on your ET tube, there's this little pilot thing
Yeah.
that you put air in.
Mm-hmm.
The better thing is to actually hook up a manometer to measure the pressure. So when I flew, we actually had to make sure that we had no more than 25 centimeters of water pressure in the ET tube. So we actually had to measure the cuff pressure on the ground, in the air, and then coming back down, because especially in the flight environment, as you ascend to altitude due to the lower pressure, things expand. So the cuff will actually expand and put more pressure in. So a lot of times we would have to actually just hook up our manometer here and
Mm-hmm.
like kind of like pushing on a valve stem in a tire to let out some of the air. We would
Yeah.
have to deflate it a little bit so that this pressure went down. That doesn't really affect you as much on the ground because you're not changing atmospheres unless you're like in a mountainous terrain or something and you're coming down to like you're either going up or going down altitude in the mountains, but otherwise it's not going to really affect you that much. But we still should be like the standard is to actually check the cuff pressure with a manometer and never put more than 25 centimeters of water pressure. But ideally, don't put a whole 10 cc's of air, just put about 5 cc's of air. You want just enough to hold the cuff or just enough to hold the tube in place.
Okay.
Okay. So explain that back. Explain the difference between cuffed and uncuffed tube.
So a cuff tube would just provide a little bit more protection to the airway, so things couldn't get back down past the tube and into the lungs, and an uncuffed
Correct.
would allow fluids and things to get in there.
Yes. And for peds, sometimes they use uncuffed tubes, but like if you get a choice, a cuffed is definitely, it's going to offer more protection always.
Yeah, that was going to be my next question. Would it be preferred to use a cuffed over uncuffed if you had the chance to do it?
It is preferred. You just don't want to overinflate the cuff because you don't want to be pushing on the walls over here and causing tissue ischemia or tissue necrosis.
Okay.
Okay.
Yep.
Anything else?
Oh,
actually, here's a picture right here. This is a picture of this is a cuffed and this is an uncuffed tube.
Sweet.
Okay.
Yep.
All right. What else? So tell me again, what's the formula?
For uncuffed, it's age divided by 4 plus 4. And for cuffed, it's age divided by 4 plus 3.5.
Okay, say it again. So for cuffed, it's what?
Cuffed, it's age divided by 4 plus 3.5.
Okay. And then for uncuffed?
Age divided by 4 plus 4.
Okay. All right. And yeah, I'll actually add this to the comprehensive study guide. I'll do this as soon as we get off the call. Anything else?
No, it's good. Thank you.
Yeah. And if you have any other questions, don't hesitate to reach out. But man, I'm telling you, your knowledge has gone through the roof. Like I can see the difference.
Oh yeah, it's like I said, I've had so many aha moments, and some of them were little, some of them were massive, and I'm like, oh man, like I actually can't wait to test now because I'm looking forward
What
to
have been your biggest moments so far?
it. So a lot of the using your study guide with the Murphy sign and Kerr sign, like those
Hmm,
were big, like the abdominal. I for some reason I had a lot of abdominal injury test questions, but they were very like vague, and it was I just could not remember for the life of me what organs were in what quadrant of the abdomen. But using your
okay, so
study
tell me
guide,
which is which.
so like right upper quadrant, that's going to be like your Murphy sign if it's a liver or a gallbladder injury. Left upper quadrant would be your Kerr sign. It's going to go over to your left shoulder for your spleen injury.
Okay.
Uh, so like things like that, and then like right lower quadrant pain is like your pancreatitis from injury or swelling to your pancreas. Like I had all those questions, and for
Wait,
some reason, like
hold on. You said right lower quadrant and you said pancreatitis. That's not how
yeah,
I would say it.
isn't it where you would have right lower quadrant pain? It could be your patient has pancreatitis.
So let's think about this. In your right lower quadrant, that's down here. What organ is the main thing that we're worried about here?
Appendix.
That's going to be appendix. So that's going to be more appendicitis.
Okay, so yeah, flip flop.
Pancreatitis, so your pancreas kind of sits here. Okay,
Okay,
so pancreatitis is
I
going
might have
to
just
be
mixed them up.
more pancreatitis is going to be more epigastric pain with radiation toward the back.
Okay,
Okay, pancreatitis more epigastric pain, radiation toward the back. Appendicitis is more right lower quadrant pain. What's the point that we use to figure out if they have rebound tenderness?
um,
So
mm,
let's say this is their hip and this is their belly button. So halfway
cannot think of
between
the word.
so this is the iliac crest and this is the umbilicus. So we're going to go about halfway between those two, and that point is going to be, what's that point?
I cannot think of the word. I was just studying this last night too. I cannot think of the word.
Okay, so that point right here, that's going to be McBurney's point. Okay, and so what we're doing is we're pressing down gently and then we let up to see, does it hurt when we let up?
Okay.
Okay, because if it hurts when we push, that's called tenderness. If it hurts when we let up, that's called rebound tenderness, and that's what we're looking for, is positive rebound tenderness. Okay, so the other thing, so appendicitis, we're looking for positive rebound tenderness, possibly positive fever, probably tachycardia, things like that. Signs of sepsis. Okay.
Mhm.
The reason it's so life threatening is because you can dump all of this fecal material into the abdominal cavity very quickly. That can end up getting into, it can make its way into the bloodstream, now circulate, and now they have sepsis. Okay. So a ruptured appendix, like appendicitis that leads to a ruptured appendix, is a surgical emergency. They can die from septic shock. Okay.
Yeah.
Okay. What if they have like a very rigid abdomen? Like if
Could be
their
like some
abdomen is very hard, what is that more of a sign of?
um could be either like internal bleeding or like
Okay. So that probably could be some kind of massive internal bleeding. I would agree with that. What else could it indicate?
could it be like a peritonitis?
It is. So that would be like peritonitis. And what is peritonitis?
It's like the inflammation of the stomach lining.
Yeah,
I
but
think.
it's there's something irritating it. So typically there could be like some kind of pus or inflammation that's irritating the wall. And that's what's causing it to be so distended, because your body, your muscles start tensing up to kind of hopefully push some of it away.
Mhm.
But in turn, that's going to cause the abdomen to be distended or rigid. So we're looking for rigidity. So I say turds. So tenderness, rigidity, or distension. Okay. So if they describe a patient with a tender, rigid, distended abdomen, or at least a rigid abdomen, we're thinking the two top things are going to be bleeding or peritonitis. Okay. Okay. What if you have stuff spilling out of the guts? Like, what if you have an abdominal evisceration? How would you treat that?
You gotta cover it with like moist, sterile dressing and rapid transport.
Okay. Moist, sterile dressing and what? Because moist keeps it wet, but you also want to keep
Occlusive.
it protected. So you want to also
occlusive.
use some kind of occlusive dressing like plastic wrap.
Mhm.
And so sometimes ambulances will literally carry plastic wrap, like saran wrap on your truck. Or you can take like the IV bag. You could, if you have nothing else, you could take like the bag that like a liter of saline comes in, and
Mhm.
just the part that's on the inside, that's, you don't want to use the outside and put it directly on the skin, but the part that's on
Yeah.
the inside, put that on the skin, cover it up with like silk tape on all sides. So moist sterile dressing first, and then the plastic wrap on top of it to seal it off from the outside
A
environment.
BVM bag. Most of the time, your BVMs come in a big bag. That works
Yeah,
well
BVM
too.
bag would work. It's actually a little more flexible also, because the IV bag is a little more stiff. So a BVM bag would work well. Yeah. Okay. So yeah, we covered care sign with referred left shoulder pain. Murphy sign, so that's typically going to be what organs over here? Well, it's going to be more here.
The gallbladder and the liver.
Yep, gallbladder or liver. Okay, let's talk about gallbladder situations. All right, so let's draw in a liver. So where's the liver located, by the way?
The right upper quadrant.
It's in the right upper quadrant below what? What's that big muscle what's this
The
big
diaphragm?
dome-shaped muscle? Diaphragm, okay. So the liver sits in the right upper quadrant just below the diaphragm. Okay. And then right below that is the gallbladder. Okay. Now, so with Murphy sign, we could have like when you press. So what is Murphy sign?
It's going to water.
It's
Now
when you
notice we have a McBurney and we have Murphy. Those are different. So in Murphy sign, what is the actual sign?
it's when you if I remember right, it's when you palpate the right upper quadrant and they have a referred pain to their right shoulder from when you palpate
Okay.
the
And it's primarily when you palpate on inspiration. You have them breathe in, and as you're pressing, and if as you're breathing in, as they're breathing in, they now have either pain here or pain to their right shoulder. That would be a positive Murphy sign, but it's
Okay.
palpation on inspiration.
Okay.
Okay. Now, what if they have a gallbladder problem? What are our options here? Okay. What if you have gallstones? What's that called? So if I put stones inside the gallbladder, then now I have gallstones. What's the word for that?
Drawing a
Okay.
blank on that one.
Okay. The word for stone is lith. Gall is chole. So if I put those together, it's going to be cholelithiasis.
Okay.
So cholelithiasis is gallstones. Now, what if I have inflammation of the gallbladder?
Cholecystitis.
Okay, so chole is gall, cyst is bladder, and itis is inflammation. So inflammation of the gallbladder is cholecystitis.
My wife just had that.
Okay. Cholecystitis is inflammation of the gallbladder. Cholelithiasis is gallstones. Now, what if you have a blockage of the common bile duct? So here's your, here, let's do it this way. Let's zoom in on this. So here's a gallbladder. Okay. And it feeds into the pancreas. Okay. Well, no, let's say it differently. The pancreas, this is your pancreas, and then your gallbladder, they come together in what's called the common bile duct. Okay. Common bile duct. So if I have inflammation of the gallbladder, what's that called again?
Cholecystitis.
Cholecystitis. If I have inflammation of the pancreas, what's that called?
Pancreatitis.
Pancreatitis. But what if I have inflammation of the, or let's say I put a stone. Let's say I have a stone that starts off in the gallbladder. When it's there, it's called what?
Cholelithiasis.
Cholelithiasis. But what if this stone now gets wedged in the common bile duct? Okay, so think about it here. If I have this situation, now stuff can't drain from the gallbladder, so the gallbladder gets bigger. So now I have cholecystitis. But if things can't drain out of the pancreas, now the pancreas gets bigger. I have an obstruction in the pancreas that'll lead to pancreatitis. Okay? So if they describe a situation where you have inflammation of this and inflammation of this, it's probably an obstruction here. And that's going, you know what that's called? Where you have a gallstone in the common bile duct.
Something lith.
Okay. So this is going to be choledocholithiasis. Okay.
Gotcha.
Chole, that's for gallbladder. Doco, common bile duct. Lith, stone. Asis, condition of. So choledocholithiasis is a stone in the common bile duct that will also lead to inflammation of the gallbladder, so cholecystitis, and inflammation of the pancreas, so pancreatitis. Okay?
Yep.
All right. Who gets this? Who is the patient who gets cholelithiasis primarily? It can happen to anybody, but the person who's higher likelihood of this is deep fried fatty foods.
Okay. I was going to say fatty foods.
Real quick, Joshua. I'm sorry. Another thing I just learned about this because my wife just dealt with this.
Yeah.
Is recent pregnancy.
Yes. And that's due to
apparently it affects
estrogen
like
surge.
80% of people after pregnancy because my wife just had to have her gallbladder removed because of this exact thing. Okay.
And it's due to the estrogen surge, like just due to the hormone fluctuation of estrogen. All right. Is this making sense?
Yeah.
Okay.
Yes.
So like he said, so recent pregnancy could be this. Deep fried fatty foods is a high likelihood, especially when it comes to the gallstones. All right. Pancreatitis. Who gets this? Who is your patient who has pancreatitis, chronic pancreatitis?
I don't know why I'm thinking like alcohol.
Okay, alcohol could be. I don't think it's number one now. Number one is probably obesity. And also estrogen. Okay, so obesity, high incidence of estrogen. Alcohol is probably a little further down the list now, but alcohol abuse, chronic alcohol abuse. How does this patient present? Where's their pain again for pancreatitis? Because where's the pancreas located? Well, the pancreas is here. So the pain is more epigastric pain. All right. So this is going to be epigastric pain with radiation where?
To the back.
With radiation toward the back. Okay. This is going to be your cholelithiasis or cholecystitis. This is going to be more, just because of where the gallbladder is, it's going to be more of the right upper quadrant, but it also may be worse after eating. Okay. Pancreatitis could also be worse after eating. Why? Because right after you eat, your pancreas now your pancreas has two jobs. You have an endocrine pancreas and you have an exocrine pancreas. The endocrine is what does the hormones. The endocrine part is what does your hormones. Remember, you have an alpha, beta, and delta. The alpha does what? So your endocrine pancreas does your hormones. You have alpha, beta, delta. Alpha makes what? Glucagon.
Glucagon.
Beta makes?
The insulin.
And delta makes? Somatostatin.
I cannot remember how to say that word for the life of me. Somatostat.
Okay. So, but those are the endocrine jobs of the pancreas. These cells are your cells that make up the islets of Langerhans. Your alpha cells make glucagon. Your beta cells make insulin. Your delta cells make somatostatin. That's the endocrine job. But the pancreas also has an exocrine job. Exocrine. Okay. And the exocrine job is what makes digestive enzymes. So the reason pancreatitis can also happen, or they have pain after eating, is because after you eat, now your pancreas has to start secreting more enzymes to help digest your food. Okay, so both of these things could be a pain that's worse after eating. Okay. Okay, nice. Okay, spleen. Let's talk about the spleen for a second. What's the job of the spleen?
God, I forget.
So the spleen is an immune organ. Okay, it helps deal with infections. So B cells, T cells with infection, but it also it kind of filters the blood. So it holds a lot of blood. What else do we know about the spleen? It's a solid organ. What do we know about solid organs? They bleed a lot.
Bleed a lot.
All right, let's come back to spleen for a minute. What are the solid organs?
Your ACLOPs.
Okay, which one of you said that?
Me.
Billy? Okay,
Yeah.
So what is ACLOPs?
Your adrenals, kidneys, liver, ovaries, pancreas, and spleen.
Nice. All of these organs are solid organs. They bleed a lot. Okay. So if you damage any one of these, you can have, so let's say you have a splenic laceration due to trauma. This could definitely cause massive internal bleeding and send them into hypovolemic or hemorrhagic shock. Okay. Who else has a spleen that gets big? So this spleen can get filled with blood because it naturally has blood in it. It normally has blood in it. But let's say you get a whole bunch of blood, the spleen gets bigger. What's the word for spleen getting bigger? So big spleen equals splenomegaly. Megaly means enlargement of, so splenomegaly is enlarged spleen. What is hepatomegaly? Hepato means liver. So hepatomegaly is
enlarged liver.
Enlarged liver. Okay, so splenomegaly. Who is the patient who gets this, though? Who is the patient who's likely to have a ruptured spleen?
Like besides
so it could be
trauma
trauma.
patient?
Say it again.
I was going to say besides like a trauma patient.
Trauma. And who else?
I don't know why, but like drug abusers are coming to mind for some reason.
That can, that could, like IV drug users could be a situation. That's probably less common. What's more common is a viral infection. So who else gets splenomegaly? A viral infection. And what virus? This is going to be cytomegalovirus. That's going to be the virus that causes the infection mononucleosis. So the kissing disease. Okay, or somebody drinking water behind somebody else. They get a viral infection, cytomegalovirus. That virus causes the infection, mononucleosis. So you have like a teenage kid who has mono from drinking behind somebody, or, it's called the kissing thing, just from transport through saliva. So let's go over that again. Big spleen. Splenomegaly could be caused by a viral infection from cytomegalovirus. That's the virus that causes mono. Who gets it? Sharing saliva, drinking water, kissing, things like that. Okay. Who else can get this? A ruptured spleen could be primarily trauma, some kind of high velocity or high mechanism of injury trauma could cause that. Okay. Who is this patient with cholecystitis or cholelithiasis?
Fatty foods.
Fatty
Deep fried
foods.
fatty foods, recent pregnancy, things like that, or they're on certain cholesterol medications that actually predispose them to gallstones. Okay. What about pancreatitis? Who's our patient there?
Obesity.
Okay. Obesity, high estrogen count, alcohol abuse. Oh, the other thing is calcification. So excess calcium. So that would be hypercalcemia is how I should say it. Hypercalcemia. Okay. Who has hypercalcemia? Who is the patient who develops hypercalcemia? This is going to
dialysis, like kidney disease and things like that.
Some kind of kidney failure, also cancer. Some kind of chronic illness or cancer can lead to hypercalcemia. Hypercalcemia can lead to pancreatitis. Okay. And the reason I'm saying this is it's important to know sometimes who is the patient who's likely to have one of these things. Okay. Another example. This just came to my mind. Let's say, all right, you know how you have your heart, and then as blood leaves the left ventricle, it goes through the aortic valve into the aorta, right? Here, actually, let's do this over. Let's do this in black. So as blood leaves the left ventricle, it goes through it goes through the aortic valve, and then it gets into the aorta. And then you have your aortic arch. We've got your 3 branches. Okay. Now, let's talk about your aortic problems. So let's say you have an aortic dissection. You could have an aortic dissection. You could have, well, first you'd have an aneurysm. Then you'd have a dissection. Then you have a rupture. What's the difference? Actually, let's write that a little better like a line. So this is kind of the continuum. You have an aneurysm. You have a dissection. And then you have a rupture. Which is which? What's an aortic aneurysm? So they're all problems with the aorta, but what's the aneurysm?
Like an occlusion almost.
Like
so
a clot.
The aneurysm is where you have this kind of bulging out of the aorta. Okay. And the problem with this, especially if it gets greater than, so if we have a diameter here, greater than 5 centimeters, that requires surgery. Okay. And the reason for it is as it gets bigger, as this bulge keeps getting bigger and bigger and bigger, it's likely to dissect or rupture. So the aneurysm is this kind of bulging out. And the reason that's a problem is blood kind of, let's put some old blood over here. You can have old blood that just kind of accumulates in this pocket and forms a clot. And if you form a big clot, remember the aorta is the largest artery. So now it can prevent blood from coming through this aorta. Okay.
Mhm.
So that's an aneurysm. Now, what's a dissection? A dissection is where, so how many layers of the
3.
artery do you have?
3.
3. Okay. What are the, oh, Lucian, you should know this. I remember you answered this question. What are the layers? Okay, so blood should be inside in what's called the
Mhm.
lumen. Okay, so the blood is inside in the area called the lumen. The lumen is just the word for hole. This is the lumen. Okay, but what is this first layer called?
I'm thinking
What's this
endo,
first layer?
myo, and then there's a
No,
third.
that's layers of the heart. We're talking about layers of the artery.
You know, I
So this,
specifically remember you talking about it, and I'm drawing a blank.
okay, so the innermost layer or the most intimate layer is the tunica intima.
Mm.
Okay, then we have the tunica. What's this one? Well, this. What's this layer called?
I know one's the tunica maxima, I'm pretty sure,
Not
but it's not that
maxima.
one.
Not maxima. Okay, so
Uh,
this is the tunica media. Here, let's put it in red. This is the tunica media. And then on the outside, we have the tunica externa. What's a dissection? It's where you get a tear in the tunica intima. Okay, an aortic dissection is where you have a tear in the tunica intima, and then this is what happens. The blood that was inside the lumen now starts leaking out, and now it goes between the other layers. That's an aortic dissection. Okay, what's the rupture? Here's your aorta, and we get a big hole in it. And now all this blood under high pressure that was inside here, it just leaks out everywhere, and it spills out throughout the whole abdomen. Okay, and this person dies almost instantly because they lose like a whole lot of blood in seconds. So even if they had a cardiothoracic surgeon standing over them, they'd probably die because it's just massive blood loss instantly. Okay.
Mm.
So now, who is the patient who gets all of this? Who's the patient who's likely to have any of this? Primarily elderly compared to young. It can happen at any age, but it typically happens with people who are older. Male, female, it could happen. It tends to happen to more males, but it could be equal. But somebody with chronic hypertension. Poorly controlled hypertension is the biggest cause of this. Smoking. Okay, because smoking constricts the blood vessels. And when you constrict the blood vessels, that increases the resistance. And when you increase the resistance, that increases the pressure. Okay, so smoking leads to hypertension. Hypertension leads to all of these things. All right, so give me that again, Billy. Man, you get your own little private session today. Okay, so let's go over these aortic problems again.
So, like an aneurysm is when you have an occlusion and from old blood and backing up and forms like a clot.
So,
And
and I don't want you to say occlusion primarily. I just want you to say a bulging.
okay,
Okay, so it's where you have this bulge. And what happens, the reason it bulges out first, I mean, yes, you can have an occlusion, but that's not the first problem. The first problem is there's high pressure in the wall, because remember, they have high blood pressure, and that extra pressure starts pushing on the wall and pushing it out. But
okay,
when you now push on the wall, what it does is it thins the wall. Now the wall gets thinner because there's constant pressure on it. And as
gotcha.
that wall gets thinner, it gets weaker. And as the wall gets weaker, now it's more likely to the layers are likely to just dissect. And when you have the dissection, that's where blood now leaks out from the tunica intima and leaks into other layers. And then if you keep having more pressure, the pipes just burst. And now you have an aortic rupture. All right, give me that again.
So you get like a bulge in the aorta from old blood, and
Well, not from old blood. No. Oh, let's do it this way. The first thing that happens is you have an increase in pressure, and that pressure causes the pressure leads to a bulge. Now, something else that can happen is now blood can accumulate in that bulge, and that blood can now lead to a clot.
Okay.
But the first thing that happens, okay, so let's do it this way. The first thing that happens is you have the pressure that leads to the bulge.
Okay.
But then once you have this pocket, now blood can start accumulating in that pocket, and that blood can now form a clot.
Okay.
Okay. Tell me, what's the starting point, though?
So high pressure in the aorta can form a bulge.
Yes.
And then which
pushes
can
it out.
accumulate old blood, but which pushes it out, forms the bulge.
Yes.
And then it can lead to a dissection from the tunica intima into the media.
Okay.
When the blood starts to leak out, which can eventually form into a rupture where it comes completely out of the aorta.
Okay. Now, in an aortic dissection, what's going to happen? If blood is starting to leak out other places, what happens to the blood pressure?
It's going to drop.
Right. Because it has to be inside the aorta for your body to measure it as blood pressure. And if it's now leaking out of the aorta, your blood pressure drops. So this is why, for instance, on one side versus the other side, in one arm versus the other arm, you may have a difference in the systolic blood pressure.
Mm-hmm.
Okay. How does this patient present, though? So they probably look shocky. They probably are hypotensive, or at least they're hypotensive in one arm compared to the other, depending on which side it's on.
All right.
And so they're probably going to have some kind of perfusion problem. Everything is oxygenation, ventilation, perfusion, right? So they're probably going to have a perfusion problem, probably signs of shock, and then they have pain radiating where?
It's chest radiating to the back.
Yeah, so this is going to be a tearing sensation with radiation to the back. Okay?
Right.
And then the rupture, they're likely to be dead. Okay? Because, I mean, there's like, if they have a rupture, there's almost nothing. They're almost 100% fatal.
So is the bulge from the aneurysm is what you would feel sometimes if you feel like the pulsating mass in their stomach?
You could, yes.
Okay.
Especially as it gets larger. Like if it's, let's say if it's only like 2 centimeters, you may not notice anything. As it gets greater than 5 centimeters, yes, you may have what's described as a pulsatile mass.
Okay.
Okay. Is this helping?
Yeah.
Okay.
Yeah.
Let's see.
This is definitely a great refresher, especially all that abdominal stuff.
Okay.
I enjoyed that.
And I'm telling you, drawing these, I mean, you obviously see me draw pictures constantly, right? But I don't just do it to impress you with what I can do. I do it to give you an example of what you should do. Mm-hmm. So constantly draw these pictures. Like I can figure out so much from just a picture more than I can just reading a PowerPoint slide.
Yeah.
What else? All right. How are you on OB?
Better than I was. There was a couple of aha moments there too, even like with the placenta previa, placenta abrupto. I remember getting a lot of questions on that, and I was getting them confused. So it helped me there.
So which
too.
is which?
Placenta previas are going to have vaginal bleeding with no pain, and placenta abruptos are going to have vaginal bleeding with pain.
Okay.
And so the placenta abrupto is the placenta tearing off of the cervical wall, correct? Causing that bleeding?
The uterine wall.
or the uterine.
Uh-huh. Okay. So in the abruption, so here's the uterus. All right. Here's the cervical os, the vaginal canal, and so let's put in some fallopian tubes. Let's put in some ovaries. So in an abruption, so this placenta is kind of attached to the uterine wall. It abruptly tears, and that's why it's painful. Think of anything that just abruptly happens, that's painful. So when it abruptly tears, so it just rips apart. Of course, that's going to lead to massive bleeding. Okay. Now, what is placenta previa?
It's blocking the uterine opening or the cervical opening.
Yeah.
It
So
could be
this now
partial or complete.
we get a preview of the placenta there instead of a baby. Okay. So now we have a preview of the placenta at the cervical os. And then the baby is behind here. Okay. But in either case, the placenta is not where it's supposed to be, so we can have bleeding. How would we stop this bleeding?
TXA?
Okay, depending on your protocols, that could be. But the biggest, all right, so it depends on how much bleeding. So we're not going to put like direct pressure on the vagina, but what we will do is use like a large pad to help just kind of tampen out some of the blood, to help it hopefully just kind of clot off, just due to the pressure of it kind of blood accumulating in the galls and putting pressure on the vaginal canal. Hopefully that'll kind of tampen out the blood to start it off. So we'll just put a large like abdominal pad there. Or we may even try like a fundal massage. Now, we primarily do a fundal massage after birth, but if they have a large amount of bleeding, we can try a fundal massage even prior to birth. Okay. Obviously, we're going to treat for shock and rapid transport if it's a lot of blood. Okay. Let's talk about nuchal cord. What's the nuchal cord?
When the cord is wrapped around the baby's neck.
Okay. How do you relieve that?
If you can you can try to just slip it over the baby's head.
What if you can't?
Lift the baby's head off the cord so you can feel it pulsating again.
Well, so that's more of a prolapse cord, but a nuchal cord is where it's wrapped around the neck. So yes, you want to try to lift it over the baby's head, but what if it's so tight around their neck that you can't get it past their jaw over their head? Then what do you do?
Clamp and cut.
Yeah, clamp and cut. Because is it an oxygenation, ventilation, or perfusion problem?
Turning into a perfusion issue and they don't ventilate, so yeah, perfusion.
Okay, so it's a perfusion problem because blood is flowing through the umbilical cord. It's also an oxygenation problem because oxygen is carried in the blood through the umbilical cord, and they're probably not going to be able to breathe like that either. So it's all three.
Yeah,
it's oxygenation, ventilation.
I guess my question
perfusion.
is, how's it a ventilation issue if the baby's still? I can understand if the baby's head is out, but if they're still inside, the babies technically aren't breathing
So it
yet.
just kind of depends on the time period. It depends on whether or not the baby's lungs have been activated to trigger a breath yet. So timing is an issue there. But definitely it's going to be an oxygenation and a perfusion problem. But if the baby's lungs have now been activated, it's also a ventilation problem.
Right.
Okay. Let's talk about the umbilical cord. So the umbilical cord, how is it? What's special about it compared to other veins and arteries?
2 arteries, 1 vein.
The vein.
Yep. So you have 1 vein, 2 arteries. Okay. So normally I would put arteries in red, except in the umbilical. I'm putting it in blue. So this
Is
is
the veins bigger?
This is an artery, and this is the vein.
The veins oxygenated blood, right? And
yes, and that's the exception. So the vein, the umbilical vein, carries oxygenated blood or oxygen-rich blood, and the umbilical arteries carry oxygen-poor blood. Where else do we see this exception? Because normally veins are deoxygenated or underoxygenated, and arteries are oxygenated. But where else do we see this exception?
Gosh, I remember you saying it.
What's the opposite of bond?
Wait.
Pulmonary vein stenosis?
Yep. So pulmonary
That's when
veins
underoxygenated blood goes through a
and
hole or something
pulmonary
and
arteries.
passes through.
So pulmonary veins, remember, this is how how does blood travel through a pulmonary vein? From where to where? Remember, you have
Goes from the
4
heart to the
pulmonary
lungs.
veins.
Goes from the heart to the lungs.
Does it go from heart to lungs?
no, lungs to heart.
It goes from lungs to heart.
Oh.
Back from the lungs to the left atrium, it goes through the 4 pulmonary veins. And because it's already made it to the lungs, that's where it picked up the oxygen. So now it's going to be oxygen rich. But the pulmonary arteries, you have 2 pulmonary arteries, left and right. And where does blood go from what to what?
Heart to lungs.
What part of the heart?
The
atria, right atria.
No.
Right ventricle.
Okay, right ventricle to the lungs. All right, so let's go over blood flow, because this is something that you either know it or you don't. How does blood flow?
Personal, right atria. Oh, well, it goes from the
inferior
Right.
vena cava, super.
Okay,
Inferior
superior
vena
vena cava, inferior vena cava, coronary sinus,
yeah,
into the what?
right
right
atria.
atria.
Okay, into the right atrium. Then it goes through a valve. What's this valve?
Tricuspid.
Tricuspid valve. Then it gets into the right ventricle.
Ventricle.
From the right ventricle, it goes through the
Pulmonary valve.
pulmonary valve into the
Lungs.
well, first it has to go to the pulmonary trunk, and then from the pulmonary trunk, it goes to the right pulmonary artery, left pulmonary artery, into the lungs. And that's what we were just saying. Pulmonary arteries, it goes from the right ventricle to the lungs. Okay, these are pulmonary arteries. And then once it picks up in the lungs, that's where it picks up all this oxygen. Okay, and on the way back from the lungs, it leaves both lungs, and it goes to what? It leaves both lungs, and it goes to the
left atrium.
left atrium through the 4 pulmonary veins. So let's put in our 4 pulmonary veins. We've got our 4 pulmonary veins, and now blood comes back into the left atrium. Now we have oxygenated blood in the left atrium. Then it goes through a valve. What's this valve?
Bicuspid.
That's your bicuspid, mitral, bishop's mitre, whatever you want to call it. Then it gets into the
Left ventricle.
left ventricle. So that's also oxygenated. Then it's going to go through another valve. What's that valve?
Aortic valve.
Aortic valve. From there, it's going to go into the
Aorta.
Aorta. The ascending aorta.
Huh?
The ascending.
Well, so first we have the part that goes up is the ascending, and then
And you
the
got the
aortic
arch.
arch,
Descending.
and then the descending. Okay. What if we have an aneurysm in the ascending? That's called a what type of aneurysm? If it's in the ascending versus the descending?
Ascending aneurysm. I'm not sure.
Okay. So by the way, we have different aneurysms. The one that's called a triple A is the one that's down in the abdomen. But the aneurysm can be here, here, here. It doesn't matter. It's only called a triple A if it's down in the abdominal cavity, because that's an abdominal aortic aneurysm. Okay?
Okay.
But the one that's the ascending limb, that's a type A. That's the ascending. And then a type B, and this is from the DeBakey classification, a type B is the descending. Okay? Type B is the one that most often gets surgery.
Okay.
Okay? Now, after blood leaves the aorta, then where does it go?
Goes to the rest of the body.
Okay, well, so it's going to go through arterioles, then it's going to go into capillaries, then what?
Venules.
Then it gets into venules, then it gets into veins, then it gets into big veins like the superior vena cava and inferior vena cava, the largest. So the largest veins are superior inferior vena cava. The largest artery is the aorta. Okay, let's run this back. Blood comes into the right atrium from three places: superior vena cava, inferior vena cava, coronary sinus. It goes into the right atrium, through the tricuspid valve, into the right ventricle, through the pulmonary valve, into the pulmonary trunk, into the left and right pulmonary arteries, into the left and right lungs. From the lungs, blood travels through the 4 pulmonary veins, comes into the left atrium, goes through the bicuspid valve, into the left ventricle, through the aortic valve, into the ascending limb of the aorta, the aortic arch, and the descending limb. From the aorta, then it goes into arteries, then capillaries, venules, veins, back to the superior inferior vena cava. And then it just keeps doing this over and over and over. Okay? Which side of the heart is the under-oxygenated side? The right side.
Right.
It's under-oxygenated and it's low pressure. On the other side, on the left side, it's oxygenated or oxygen-rich and high pressure. Where's the highest pressure in the body? Right here, in the aorta. Okay? That's where blood pressure is actually coming from. Like when we measure blood pressure, it's pressure right here. Let's talk about this. What is preload? Preload is the volume of blood that ends up coming into this left ventricle. So theoretically, what comes into the right side also ends up in the left side. But when we say preload, we're primarily talking about the volume of blood that comes into the left ventricle. What medication can drop preload? Nitro, because it's a venodilator. What is afterload? Afterload is the resistance that we have to overcome to get blood to push out of here. So what can drop afterload? Vasodilator, also nitro, also calcium channel blockers, or anything that's a vasodilator. Okay, how are you feeling about all that?
Good.
Okay, any questions?
I think it's good to go for left ventricular hypertrophy with that image as well.
Okay, let's do it. So left ventricular hypertrophy is where this ventricle is getting bigger and bigger. Okay, now when it comes to left ventricular hypertrophy, you have two different flavors of it. You have something called eccentric hypertrophy and concentric hypertrophy. You don't have to know, you probably were not taught this part yet. Eccentric is where it's a volume problem. Concentric is where it's a pressure problem. Okay? Where it matters is the heart murmurs that are associated with it. In eccentric problem due to a volume overload, this is where you're going to have an S3 heart sound. And in concentric hypertrophy due to a pressure overload, here, let's put pressure in red. Let's put concentric pressure Put that in red. And that's where you're going to have an S4 heart sound. What's the difference? A normal heart sound is S1, S2.
Lub dub.
This is lub, dub. But in an S3, is this. You have S1, S2, S3. So some people will refer to this as Kentucky, Kentucky, Kentucky. So this is your Kentucky sound. On the other hand, your S4 heart sound is this. You have your S1, S2, but then you have an S4 in front of it. So it's really S4, S1, S2. So some people will call this Tennessee, Tennessee. So Tennessee, Kentucky. Did you learn that?
No.
Never.
Okay. Well, don't worry about it. You sure they didn't go over like Kentucky and Tennessee? Okay.
Definitely not.
Okay, that's okay.
I remember going over like S1, 2, 3, and 4, but
Okay.
and the primary difference that we're talking about versus eccentric and concentric is basically like the amount of volume. So like
Yeah.
one of them, there's not enough
So let me
blood
show you what it
volume. The other
actually looks
one,
like. Let me show you what it looks like practically. In eccentric, it's more of a volume problem where this ventricle is actually stretching. In concentric hypertrophy, it's more so that this muscle is getting thicker. So this muscle is getting like really thick. And in this case, what's happening is the muscle is getting so thick that it's decreasing the amount of volume that you have inside of here. So it's decreasing the filling. So filling is diastole. So diastole is when blood fills up. So this is what's called diastolic heart failure. Okay. Diastolic heart failure is where you have concentric hypertrophy due to pressure overload. Okay. Eccentric hypertrophy is where you have a volume problem and the ventricle is stretching out. And so because it's getting stretched so much due to the Frank-Starling reflex, it's having a hard time squeezing. So now you have too much volume and stretching, and that's going to lead to systolic heart failure. Okay, so when it comes to left-sided heart failure, it's either systolic or diastolic. The diastolic is the pressure problem. The systolic is the stretching problem.
what signs
Did I
and
confuse
symptoms
you?
are associated with this?
Say it again.
What signs and symptoms are associated with this?
Okay, so with heart failure, let's say if it's a systolic problem, so I want you to kind of reason through it with me. If you have a systolic problem, you're going to have a harder time squeezing. Okay, so if you have a harder time squeezing, then that means that, are you going to pump? Like if it's hard to squeeze the blood out, do you pump out a lot of blood or pump out a little blood?
You're not going to pump out enough blood, so there could be blood pooling.
Well, you're not going to pump out enough blood. There could be blood backup, yes. So now if I don't pump out a lot, this blood accumulates. So first it's stretched out there, but then it starts backing up, and then it's going to eventually also back up to the lungs. So now I'm going to have breathing problems. Okay, but I'm also going to have decreased cardiac output because I'm simply not pumping out enough blood with every heartbeat. Does that make sense?
Yeah.
So decreased cardiac output is going to be all your perfusion related stuff. So they're going to be, maybe their pulse is weak because you got to have blood flow to have a pulse. So if I don't have as much blood flow, my pulse is weak, or I have a weak and thready pulse. Okay. They're probably going to be pale, cool, clammy, pale, cool, diaphoretic. Now let's talk about and some of the stuff overlaps. Let's talk about if I have a volume problem. If I have a volume problem, then what happens?
You're
I mean, I'm
pushing.
sorry. I circled this. I meant pressure problem. If I have a pressure problem where I have diastolic heart failure, what's going to happen?
You don't have enough time for the muscle to, I guess, rest to fill it back up.
Uh-huh. And if I don't have enough filling, then I don't have enough pumping.
Right.
So if I don't pump enough blood, what's going to happen?
Same thing. Cool,
Same
clammy.
kind of thing. That's why I said a lot of the symptoms overlap. Okay. It's just what's the underlying cause. But the end result is going to be very similar. You can still end up with the same kind of fluid backup that can still end up going to the lungs. So either one, left systolic or diastolic heart failure, either left-sided heart failure could end up with lung problems. So now they've got breathing problems, or it could also back up to the body, and now I have fluid backup everywhere. So remember how blood goes? It goes from the right side of the heart to the lungs, to the left side of the heart, to the body. Okay? And as fluid backs up, let's actually do it. Let's do this differently. Let's move these around. Let's do it this way. There we go. Because blood comes from the body to the right side, to the lungs, to the left side. So if it can't get out of the left side, then it backs up to the lungs. If it can't get out of the lungs, it backs up to the right side. If it can't get out of the right side, it backs back up to the body. So left-sided heart failure leads to breathing problems. But left-sided heart failure can also lead to right-sided heart failure. And right-sided heart failure leads to fluid backup in the body. Up in the neck, we have JVD. In the abdomen, we have ascites. Down in the feet, we have edema. Okay? All right, that's probably enough for today. How are you feeling about this? Like, is this helping, Billy?
Oh yeah, for sure.
Okay.
Definitely is.
What was your big takeaway from today? Because we covered a lot today. Let me show you what we covered just today. Just in this special session. Wow, we covered a lot actually. So we started off today talking about just kind of your game plan. Then we went through the 5-star medic method again. I told you how beneficial it is if you use it. Told you how everything comes down to oxygenation, ventilation, perfusion. How you want to eliminate the things through the seed tricks. We talked about how when you know oxygenation, ventilation, perfusion, they throw in a lot of details, but it's still one main problem. So your first thing is to fix the main problem, and then your next options are to fix other problems associated with that. We talked about your fluids today, and we were throwing this in about like, okay, mannitol is the osmotic diuretic that you would use for increased intracerebral pressure or increased intracranial pressure in a head injury. And we talked about why mannitol is preferred over like saline, ringers, or definitely, absolutely not a hypotonic solution. Because if they have swelling, we don't want to cause more swelling with the hypotonic solution, okay? We talked about that. We tied in the same concept of why you don't put like a tooth in like sterile water because it damages the cell swells, the cell dies. We talked about how you have your different question types, en route, scene, and post scene. But they're still just questions at the end of the day that you still follow the same rules for every other question. We went over your perfusion equation. And we said that every cardiac med that you give, it has to work in one of these 4 places. It has to do something either to the heart rate, stroke volume, or systemic vascular resistance, and directly or indirectly is going to also affect the blood pressure. We used some examples of different meds, and we tied it right back into the same equation. We talked about cuffed versus uncuffed tubes and how to figure out the formula for pediatric patients in terms of what size cuffed or uncuffed tube. We went over your different solid organs. We talked about Care sign. We talked about Murphy sign. While we were doing that, we talked about cholelithiasis, cholecystitis. We talked about choledocholithiasis, pancreatitis. We went more in depth with that. Then we got into aortic situations. We talked about aortic aneurysm, dissection, rupture, the difference in those. Got into some OB stuff. All right. Talked about the difference between the umbilical veins and arteries and the pulmonary veins and arteries compared to the other veins and arteries in the body. These are the two exceptions. Umbilical veins and arteries, pulmonary veins and arteries are opposite the rest of them in terms of oxygen rich or oxygen poor. We went over cardiac or coronary circulation or blood flow through the body, your different aneurysms. We went over left-sided heart failure, systolic and diastolic heart failure. This is something I would recreate. Like, definitely go back over this. And what I'll also do is I can just drop this. I'll take the Zoom recording and just dump this in a replay for everybody. Okay. And then we just lastly finished with what happens in the different heart failures. Like this is a lot of foundational stuff that you must know to do well on the exam. Any questions?
No, okay. I'm good.
Have you taken the time to draw pictures like this?
Yeah, I actually try and teach my girlfriend sometimes what I've learned after a lecture, because I feel like if I can teach it, it makes more sense to me when I'm saying it to somebody.
Absolutely.
So
you often hear me say, when you can teach it and draw it, that's when you understand it.
Yeah, and it's to the point that she's starting to actually learn things, and she's not even a medic or any kind of medical training whatsoever. Nice. So, but it's working.
And then go one step further and draw pictures for her, and then it's like she got it.
Yeah.
Okay. All right, guys, this was fun. We covered 2 hours today. I'm going to go ahead and end it. Any final questions?
No, I'm good. Thank you so much.
You're certainly welcome. So this replay, actually, this will be the Zoom one because I wasn't recording in the studio. So this one will go up sooner. So as soon as Zoom emails me and I get that video processed, I will get that posted probably in the next 2 or 3 hours.
Okay, awesome.
All right. You guys have an amazing day.
You too. Thanks, Coach.
No problem. Take care, Joshua. No, I was just saying take care. I enjoyed that.
Okay, good.
My takeaway was the whole estrogen dump.
Gotcha.
Causing the stuff with the gallbladder.
Okay. And estrogen actually causes a lot of problems. It can cause vasodilation, it can cause a lot of issues. All right. Well, we're going to go ahead and end it. We'll be on tomorrow. We'll be doing med math tomorrow because that was supposed to be yesterday's topic, but I had to cancel it. So we'll be doing med math tomorrow. We'll go over drug calculations and med math. All right. Let's end it, and I'll see you guys tomorrow.
All right. Later. Thank you.
Huh?